All righty. Well, we'll go ahead and get started. Thank you all for joining us today. And it's great to see some names, faces, little black boxes with names returning and some new folks as well. So thank you for joining us. As Anthony mentioned, we're the Virginia Impact Team, and we'll tell you a little bit about us, kind of how we got here, and then talk about what we're doing and hoping to do with many of you around telehealth. I'm Lori Archibald Pinoni. So as Anthony mentioned, Medical Director of Virginia Impact and a geriatrician here at the University of Virginia. We're going to talk about telehealth, kind of coming out of the public health emergency, beyond the public health emergency. We'll talk about age-inclusive telehealth, starting a program, and then telehealth optimization. We'll have members of our impact team doing different parts of the presentation, and I'll let them introduce themselves once we get to their part. So thank you all for joining us. Let's see, Anthony, I don't think I can you advance the slides, please? Thank you. No relevant financial disclosures. Next, please. Let's start with age-inclusive telehealth. What is it and how can we achieve it? Next slide, please. So here are the learning objectives that we'll talk about: the principles of age-inclusive telehealth, try to identify practices that are not age-inclusive, share how to access and utilize national resources on age-inclusive telehealth use and implementation, and then try to identify core principles of success at facility level for telehealth optimization. Next slide. So we'll first start with a clinical vignette. So we have a person, an 85-year-old person who's admitted to our subacute rehabilitation facility following a hospitalization for a ground level fall that was complicated by a hip fracture. So on day one, I go in to meet this person and establish a pain management plan, get to know them, and admit them to the facility. On day 4, receive a call from the nursing staff to report that the patient has significant pain with physical therapy. I'm in clinic, in an outpatient clinic, seeing patients booked. The clinic is not close to the facility and not planning to be back at the facility for another 4 days. So thinking, well, let's utilize video-enabled telehealth. Let's set up a telehealth appointment to evaluate this patient today so we can work with their pain management plan. So the question is, which of the following best reflects an age-inclusive telemedicine plan? So should we, A, establish an appointment time with the patient and nursing staff to conduct a video-enabled telemedicine visit? B, instruct the nursing staff to have the patient log on to the telemedicine system, and then wait for me to have a moment to connect with them, as I'm seeing during visits in the outpatient clinic. C, request that the nursing staff contact me via a smartphone, for example, FaceTime me. D, inform the nursing staff that this visit can only be conducted if the patient's able to log on to their own clinical portal. Or E, what am I thinking? Older adult patients don't like telemedicine visits, so shouldn't even be offered in this case. I'll open it to the group if anybody wants to put into the chat thoughts, or feel free to unmute yourself as well if you want to share any thoughts about this. All right, we've got a vote for A there. Well, great, thank you. So let's go to the next slide. So absolutely, so A is the most age-inclusive plan to establish an appointment time with both the patient and the nursing staff to conduct a visit, right? Set it up just like we would any other visit with an expected time so that all parties involved can prepare for the visit. B is specifically, have the patient log onto the system and wait for me. Well, that's not very patient-centered. C, request a FaceTime. That's not integrated and coordinated into the patient's medical record. D, inform the nursing staff that this can only be done if the person can log on to their clinical portal. Well, that's not really being equitable. That's not being accessible to patients. And E, assuming that older patients don't want to do telemedicine, is neither patient-centered nor equitable, accessible, or, across the board, even true. So absolutely. So A would be the age-inclusive telemedicine plan in this scenario. So what is age-inclusive telemedicine? Next slide, please. So a little bit of a background kind of how we got here. We worked with many of you through those really darkest times of COVID and early 2020 and through the Jerry Powell program. And then, we've all emerged from the public health emergency with lots of lessons learned, some scars, but moving forward, and what can we take from that experience to move forward? And so specifically our impact team, we've kind of gone from that Jerry Powell model to the impact model. So just to step back a little bit, none of us really want to go back into those dark days of COVID, but just to kind of think through at the end of December of 2019, it's when the WHO in China was informed of this new cluster of illnesses. So that's where our 19 comes from, even though most of it was 2020, but COVID-19. Then at the end of January, the public health emergency was declared in the US. As we were seeing more cases start to pop up in the US, specifically as a geriatrician and as somebody working in post-acute and long-term care, we saw some quite tragic events occurring on the West Coast in facility out there. And we're able to say, wow, we don't know what this is going to be. We don't know what we're going to do exactly, but we've got some time to prepare and we've got to get something together because this is coming and it's not going to be good. So, so in 2020, we brought a team together and, kind of named ourselves the Jerry Powell program, UVA Geriatric Engagement and Resource Integration in post-acute long-term care facilities. And what we were really trying to do is to work with all of you, work with, collaborators throughout the community to try to figure this out together. We had those daily collaborative rounds via the Project Echo model to just come together, develop a community, talk with each other, kind of talk through where our challenges were, where our PPE was coming from, just all of the things that needed to be discussed at the time. We had a nursing liaison who's really able to make those connections in the community to try to build that community together. We were initially providing on-site infection advisory consultation. Back in February of 2020, there were a lot of new regulations coming out almost multiple times a day, at least daily. It was a lot to keep up with. So the recommendations or the regulations were there, but what does that mean for an individual facility? Things are moving very quickly. So we would be on site with anybody who was interested and help to talk through, let's think about how we're going to get those albuterol, meter dose inhalers as opposed to the nebulizers. Let's think about where we're going to put the isolation unit if we need it, and kind of doing that on-site consultation, which quickly transitioned to remote once everything shut down. Started with the telemedicine consultation option for both geriatric palliative and COVID care, working with our medical students to start to form phone call social contacts for folks who are really becoming isolated in facilities, and then developing the targeted rapid response program. So March 13th, 2020 hits, and basically the world changes from there, right? So for Jerry Powell specifically, in April, we worked with our first facility outbreak, and we can tell you a little bit about more details there. We've had many of our team members now were there as well, and we worked directly with the facility to activate a contracting process to be able to provide care, provide a COVID kit, which was essentially a tablet, computer, virtual stethoscope, virtual otoscope, and a telehealth platform to be able to provide care. And we worked on daily virtual rounds with the team, which was really bringing everybody together effectively, but efficiently, most importantly, because everybody was stretched, to really in 30 minutes or less work with experts in COVID care, experts on the ground in the facility, everybody there together. Who are the patients that aren't looking good? Who do we need to see via telemedicine? Who maybe should just get sent out? How are people doing in the hospital? Who might be coming back? To really, in 30 minutes or less, get that information to all parties involved. And then that developed through. In October of 2021, the CDC put forth the long-term care and nursing home strike team infrastructure project, which is then given to the states, and then VDH received funding to start the Virginia long-term care infrastructure pilot projects, of which Impact is one of the 9 organizations funded through that. So that's a little bit about kind of our timeline and how we became Virginia Impact, which is infection mitigation, prevention, and control through technology. So that's kind of how we developed from the infection control piece. And then we'll talk a little bit more about our vision for the technology piece as the tool in infection control. Next slide, please. So thinking about telehealth and knowing that we were able to utilize it in the pandemic and then thinking about how we can use it moving forward, there are certainly times, and I'm sure that we've all had these experiences where, wow, this is so great that we're all able to get onto this telehealth platform, to be able to connect with our patient, to be able to do this efficiently, effectively, get it done, and it worked great. Fantastic. And there were times when, whoo, I can't believe we tried to do that. It did not work. Nothing seemed to fall into place. And it was more of a barrier than anything else. So what we learned is there are obviously ways in which telehealth can be a wonderful tool in taking care of our patients. And if not done well, there are times when telehealth can become more of a burden in terms of interfering with processes that we already have in place. So how can we be thoughtful in when and how to use telehealth for our patients? And so that was really the question that we started with. How can we use this tool in the best way? I would liken it that, if somebody comes in with a sprained ankle, the stethoscope is not going to be the best tool for taking care of that patient or diagnosing what's going on, right? And so telehealth is great when it's great, and we need to kind of define when is telehealth the right tool. So in reviewing the literature, both before COVID, through COVID, after COVID, there have been a lot of studies that have shown multiple benefits from telehealth in terms of both clinician and patient satisfaction, being able to deliver patient-centered care, reducing cost, reducing cancellation rates, reducing travel, a lot of things that directly impact us in our facility-based work and our patients. So kind of thinking through that, putting together a group, we can go to the next slide, please, to define age-inclusive telehealth. And so this is a collaborative project that we worked with Matrix, the Mid-Atlantic Telehealth Resource Center, and then West Health, which is a nonprofit out of California focused on healthy aging, to develop a collaborative of experts in telehealth and care of the older adult, as well as implementation across the country to really come together and define what is age-inclusive telehealth. And so we really broke it down to 3 principles of age-inclusive telehealth. That age-inclusive telehealth is equitable and accessible, patient-centered, and integrated and coordinated. So these are the 3 key principles to keep in mind when we're thinking about telehealth, especially in use for older adults or vulnerable populations. Next slide. So I won't bore you with kind of the development story there, but needless to say, with great collaborations with West Health and Matrix, we were able to put together this collaborative and establish the Center of Telehealth and Aging, which is an online resource where you can go for kind of one-stop shopping for practical guides for telehealth use, implementation in a variety of settings, including congregate care. And so they have a great resource set up on that website. Next slide. And with that, we've tried to really highlight innovators in practice, so people who are using telehealth in innovative, or programs who are using telehealth in innovative ways that are reflective of age-inclusive principles. And so we've had 2 awardees thus far, Geisinger at Home, and then the Scan Health Plan, to both highlight the great work that they're doing with older adults, rural adults, and to decrease hospital unnecessary transport and to really improve care. Both are doing phenomenal things. And really the key is that we can all be leaders in age-inclusive telehealth. And so really trying to highlight the great work that's already going on. Next slide. So with that, we've put together, we have over 40 organizations that have signed on to pledge to support age-inclusive telehealth. And this is a snapshot of the different groups around the country that are doing that. And that, next slide. Really, we're here building this movement, if you will, of age-inclusive telehealth. And so if you would also like to join that and to join that group of age-inclusive telehealth national leaders, then you can sign the pledge on the Center of Excellence for Telehealth and Aging, as well as find other resources there. So that's available to you if you're interested. Next slide. So that's a little bit about how we kind of grew into Impact, how we've been able to bring age-inclusive telehealth to the conversation, and how we would love to, start to engage across the country and getting that there, as well as, having you guys as part of being leaders in age-inclusive telehealth across the country. More specifically here, taking care of our individual patients. We'll talk a little bit about what we've been doing with Impact, and then how we've been collaborating with some of you all to help bring this kind of into day-to-day use. So with that, I will turn it over to Tabor Flickinger to tell you a little bit more about us. Thank you.
All right, thank you. Hello, everybody. I'm Tabor Flickinger, one of the primary care physicians here at UVA and part of the Impact team. So I'm going to give a little bit more detail about Impact, what it is and what we have been doing, and where we sort of see things going in the future. We can go to the next slide. All right, so just sort of an overview here of some of the areas that we've been working on, where the overall goal really is to improve preparedness through technology and evidence-based education and advice for statewide infectious disease management, particularly across congregate care environments, is kind of our focus. And so in working on that, we have kind of three main areas: infection control learning, community engagement, and then technology and telehealth tools. And some of these activities bridge more than one principle, really. In particular, ECHO webinars, which you all are familiar with and participating in, is part of our learning goal, but then ultimately we aim to use that as a way to promote a community as well, building a network of professionals who have these common interests in these topics, and ultimately forming a community of practice to support each other in the work that we're doing. And our website for Impact is currently in development, but I'm going to talk a little bit more about the technology next. So the Impact team put together an online survey built through Qualtrics and then disseminated. And the purpose of this was to elicit perspectives on telehealth from professionals working in congregate care settings throughout Virginia. And we disseminated the survey through webinar participants, through Flip partners and other networks, and ultimately had 71 respondents who had completed the survey, and they represented 34 of Virginia's 35 health districts. So we were happy about that, to kind of get a broad sample of people throughout Virginia. And the most common facility types that the respondents worked in were assisted living facilities, certified nursing facilities, and long-term acute care facilities. And some other examples were adult day centers, group homes, prisons and jails, any setting in which there was congregate care going on. And about a third of the respondents had clinical roles, and within that, the most common was nursing professionals. And then within non-clinical roles, the most common was facility directors or administrators who were responding to the survey. Go to the next slide. And so the survey asked about telehealth use in the facility over time, and we saw that about 30% of facilities were using telehealth before COVID, and then that peaked to about 79% during the public health emergency, and then currently dropped down a little bit to 64%. So we're not quite at the peak level at this point, but we're still far above pre-pandemic levels. So this continues to be an important area that facilities are working on in order to deliver care. Next slide. Yep. And so we asked about potential benefits of telehealth. So that was for people who hadn't necessarily used telehealth at their facility yet, but were thinking about it. And then also about observed benefits. So people who had used telehealth and what their experience of that was like. And this shows some of the most frequent responses in terms of benefits that were fairly similar between the potential and the observed groups there. And the sort of common themes were improving access, and improving satisfaction, and then also reducing unnecessary transport was also a big facilitator for people. We can go to the next slide. So we also asked about barriers to telehealth, both potential and observed barriers from people's experience. And we could see that there were some differences here between potential and observed experiences, where on the potential side, a lot of the concerns were around technology being too expensive, that was a barrier for people, and then also concerns about poor connectivity were some of the most highlighted areas there. On the observed side, poor connectivity was still a major issue that people were concerned about, but also highlighted the lack of consistent workflow as a problem. So that was one thing that people had frequently observed in their facility that got in the way of being able to deliver telehealth well. And so this sort of highlights, the importance of workflow, as something potentially that's within control, or at least can be modified by facilities as an area to improve access to telehealth. And when thinking about the barriers and benefits, this also sort of emphasizes that this is a multi-part issue, that any kind of interventions have to take multiple levels into account in trying to figure out how to overcome barriers while optimizing the benefits that can be derived from telehealth through that. So we can go to the next slide. And so in sort of thinking about next steps, we also asked within the survey about interest in telehealth consultations. And so respondents expressed interest both in initiating telehealth programs for those who didn't already have that going on, but also frequent interest in improvements to existing programs, wanting to figure out how to do telehealth better and how to optimize that a little bit more. And so with that information, that has sort of fed into one of our other activities, which is offering consultation by the impact team. And we're going to tell you more about that in this next set here. So thank you very much.
Excellent. Thank you, Tabor. So what we'll do at this point is just kind of address the process by which we provide consultations on a facility level. And so just to backfill a smidge here, when we talked, we've mentioned the word infrastructure a few times so far. And the money from CDC that went to VDH, both of those initiatives included that word, and we take that word seriously. And so when we consider infrastructure and telehealth as infrastructure, I try to think of it in a way that, good solid infrastructure is something that you can use and turn to and rely on in an emergency and not have to learn how to use it, not have to learn about it, kind of know what you're doing with it. And so that's kind of a theme that we keep in mind as we move about the Commonwealth in our consultation efforts. From the standpoint of facilities that would be considered in our scope, just to backfill a bit more, we mentioned congregate care settings, but that includes skilled nursing, assisted living, adult day centers, PACE centers, schools for people with disabilities, group homes, jails, and prisons. So we try to kind of consider our scope to be a fairly wide one with respect to congregate setting coverage. So I'm going to let David Cattell-Gordon, the former director of the UVA Center for Telehealth, introduce himself here, and then we'll kind of move through, like I said, our processes, and then a short case example, and kind of tie it all together here. David?
Hey, good afternoon, everybody. It's great to be on with you. I was very privileged to be the director of telehealth at UVA for a number of years. Not so lucky to have landed as director of telehealth in the middle of COVID. I had been saying, I told you so for a long time now, that we were going to get to the point where these tools became absolutely necessary from us. But I think what, in particular, what Laurie pointed out so strongly, that experience, that existential crisis that was COVID, really showed us that we needed new approaches, that telehealth couldn't be something we just brought out of the closet and blew the dust off of in the middle of a crisis. So been very thrilled to be a part of this team, both with my background in telehealth, and also I am a social worker by vocation, and community organizing is at the center of this. And I think one of the painful lessons of COVID was that these are the most vulnerable folks that we have in our communities. We already knew that going in, but it was really confirmed by the outcomes. And so we see this infrastructure as a way to reduce that vulnerability, improve communications. And we've engaged in what I think is a thoughtful process. And Anthony's going to talk about that.
Excellent. Thank you, David. So I'll briefly address what we consider core principles when we get to a facility on-site level with respect to telehealth. Optimization is a term I use a lot, or improvement, or initiation of a telehealth program. One of our another guiding theme really is try to see things from the standpoint of the staff at congregate care communities. And to be quite frank, COVID kind of laid bare issues and challenges in congregate settings that had been simmering and present for years. But and I'm talking about staffing, staff turnover, administrative and regulatory burden, and just sheer workload. So we try to see things from that standpoint, and we don't want to be an organization that comes in and says, "Here's your giant telehealth program, and here's all the equipment. Have at it," because it turns into kind of a burdensome process. And I think a successful implementation of such of telehealth technology, I think, would be better addressed in small, feasible, achievable steps. And so that's what we work on, is keeping the steps small and reasonable. We also talk about the importance of data and how that drives an improvement or initiation of telehealth technologies. And we talk about data from the front end. So if a congregate setting and staff there decide, okay, we want to initiate a telehealth trial, well, let's identify a small number of patients that data has borne out to demonstrate some need. So it could be, potentially a group of patients with the same diagnosis who end up utilizing the emergency department frequently, and you have metrics that have shown that. And so that could be the initial telehealth trial. It's a data-driven small step initial trial. And we also talk about data driving your program assessment. So is telehealth doing us any good? And so we encourage facilities to choose some relevant metrics to follow that would indicate the success or failure of telehealth implementation, or what you might need to work on. Again, that could be patient satisfaction or caregiver satisfaction, staff satisfaction, ED utilization, like I said, or transportation, those kinds of things. And then we talk about what I referred to with respect to infrastructure as being something that you can turn to in the event of an emergency or crisis, and know how to use it already. So we shoot and encourage for routine use, so that you can kind of embed or bake in some ongoing day-to-day competence with the technology. So then when COVID hits, it's not something that you need to learn. COVID part 2 hits, it's not something you need to learn. Because I was a frontline clinician at the time COVID hit, and our ramp up to COVID, it looks similar to Tabor's question with respect to telehealth use patterns before, during, and after the pandemic. It was a bumpy upslope with the use of telehealth when we adopted it suddenly, in March 2020. So ideally, get good at routine use, and it's there for the emergencies. David's been integral with respect to kind of engagement of facilities based on the relationships, longstanding relationships he has across the Commonwealth. So I'm going to let him address this slide, and then we'll explore a case example.
Thanks, Anthony. There are three things I really want to emphasize in approaching this, is that we're trying to create a model here for the Commonwealth and beyond. This is not a number of one-offs or a crisis response as we had in March of 2020, but rather a systematic way of looking at how we implement the technology. And I wanted to start with how important age-inclusive telehealth is as a concept, and really urge people to go to the site and look at that and consider supporting that pledge, because it really is an important clinical and moral issue, believing that people who are vulnerable should have access to the resource. And so that standard is what began us. The second is what Tabor really pointed to, is we really want to be data driven. We wanted to understand what we saw as the barriers and the limitations of telehealth. Too often, I think technology has driven it. We say, oh, this is going to be great for our folks. We know that it could make a difference, but we let the platforms, or we let the technology drive the process rather than relationships, rather than what I think is the third point to underscore, which is what Anthony just talked about, is the core principles we use. It is let the need for staff and the needs of patients drive small steps that are driven by the data and become a functional sort of everyday thing you do to help support those patients who need it. Then we really truly have infrastructure when we get to that point. One of the other things that was important is for us to also have a model for how we help congregate facilities, be they a jail, be they a school for folks with neurodevelopmental issue, be they a PACE program or assisted living, that we wanted to approach in a model-based way that got data. And first and foremost was to engage the leadership, to have a conversation, to really ask the question, does telehealth integrate with the mission and vision of the organization? When you have alignment with leadership and they see the financial efficiencies and the clinical efficiencies of this and see it as a way of supporting staff, when those things come together, you begin to get the key data points and understanding of need. So we went from understanding, yes, there is a desire for telehealth. Yes, it integrates with our mission. And then going to the site. And we also partnered with Mike Patterson, who is a longstanding telehealth engineer, to help go and form relationships, do an assessment with the frontline folks to say, what works and what doesn't work. I have to tell you, it's a surprising thing when you think you can walk in with an iPad and you're going to solve everybody's problem, and the answer back is, the people here don't use iPads, never use iPads. In fact, we gave them bingo on the iPads and they didn't want to use it. So we, that getting in there, forming the relationships with IT and clinical folks and frontline folks and administrators was important. And that allows us then to develop, and Anthony's going to talk about this, a model summary and consultation report that folks can actually use step by step in small pieces to drive it, and to use it for troubleshooting and problem solving. So this is what we've done, and Anthony's going to talk about what that process really looks like.
Excellent. Thank you, David. So we're going to work through a case example, and this is a real experience that's in process, and we're really proud to work with this organization. But we worked with a rural PACE center, and I'll just backfill backfill a smidge here. If anyone's not familiar with PACE, it stands for Program of All-Inclusive Care for the Elderly. And it's a level of care for frail elders 55 and older who primarily live at home. It operates typically PACE centers in general operate out of a PACE center where an interdisciplinary team works business hours, Monday through Friday. That said, PACE programs are responsible for their participants, which is what patients are called at that level of care. 24/7, the program would be responsible for the participants. So there are, in any PACE center or PACE program, there are regular times of relatively low staffing. So after those business hours during the week and through the weekend. And during those low staffing times, there's typically a registered nurse on call and a provider on call to field issues and problems from their entire census. And so we engaged with a program, and we showed up, and they basically led us through our core principles. And so they presented, one of the issues that they thought may be relevant and amenable to effective use of telehealth was that during those low staffing hours, a small number of participants make a disproportionate number of the phone calls to the on-call staff, to the on-call nurse receiving the calls. And so that's a big workload for one registered nurse to field all those calls and potentially go out and see participants in their homes and that kind of thing. And so the thought was, well, perhaps a phone call pivoting to a telehealth encounter would be an appropriate measure to help the nurse prioritize and triage to meet the participants' needs and perhaps save some visits, make the workday for the low staffing situation a little bit more efficient and that kind of thing. So they came to us with small steps, which was, we're talking about a small number of participants, 3 to 5, who were identified through data, really, who's calling a lot and why are they calling. Now, these calls can range from an emergency, an injurious fall that requires escalated care immediately. They can range from that to, I was at my daughter's picnic and ate 2 hot dogs and now my reflux is bad. Or it could be kind of a loneliness call. So those types of things, if we pivoted to a telehealth encounter, perhaps the participant with an issue that doesn't require an immediate visit or escalated care can be talked through, their needs met. Hey, maybe we can, we'll set you up for the medical clinic appointment tomorrow at the PACE Center where you can meet with the nurse practitioner and the dietitian and talk about, when to take the Tums and that kind of stuff. So that's kind of an overall overview of PACE and in general, a potential problem that could be amenable to telehealth. And so what we'll do now is I am going to stop sharing this and then just share kind of our approach that we use with respect to consultations and, again, incorporating our principles that we talk about. So let me just switch out here. There we go. Okay. So once we go through the process, we engage a congregate community through a virtual visit, and then we do an on-site visit, meet with key stakeholders. We would generate a report afterwards to kind of highlight findings and discuss a path forward. And we certainly, we address principles of age-inclusive telehealth, which Dr. Archibald Pannoni covered earlier. And then we get into, some more specific findings. And our team with Dr. Archibald Pannoni's leadership came up with a tiered approach, really. And it's they're basically 4 I words. And I find it significant, really, because, as we've talked thus far and in our team's discussions, really 2 of the most important words for us are infrastructure and infection. And so I find it appropriate that these are 4 I words, but they're initiate, integrate, incentivize, and inspire. And I'll go through each one briefly. Relevant to the case example that we talked about, which was a rural PACE center. So initiate, obviously, this is the first one. It's going to be a foundational step. And at this stage, really, we discuss, think about a team, think about a telehealth champion. We know that telehealth programs have a greater chance of success when facilities cognizant about choosing a team and a champion to kind of move forward with their telehealth efforts. And then we also just address basic regulatory needs at this foundational stage. So consent from participants for telehealth encounters, making sure that their platform is HIPAA compliant and any access, remote access to medical information is also HIPAA compliant. So basically a foundational step. We've not really moved into telehealth yet, but kind of setting the stage here in the initiate stage. As far as integrate, when we move to the integrate stage, and this isn't, so these are small steps. I think with some communities, this is like one, like in perfectly sequential order. And I think some communities or congregate settings, like the rural PACE center we met with, they've done kind of or on the verge of multiple sub-steps under each phase here. So anyway, the integrate step is kind of looking at the scope of your telehealth trial, kind of identifying the scope of it, assess needs, and engage the participants that you would want to be in the trial. And you would want, so those frequent high need participants during the weekend and after hours would be the folks you would identify. And then we consider, in this example, looking at things from the participant side of the telehealth encounter. So what does the home look like? Is there a reasonable connectivity, which is a big deal? Is there physical space that's safe to conduct a telehealth encounter? Is the lighting okay? Are the pathways clear that the participant with functional limitations could get in and out of the room safely? Those kinds of things from the participant side of the telehealth encounter. And then begin to consider workflow, kind of what would an encounter look like? If, the workflow from both sides of the encounter as you're starting to move from integrate to incentivize. And in this situation, incentivize represents a successful launch of a trial, a telehealth trial. And so we look at, in the integrate stage, we looked at the participant side of the encounter. Now we're looking at the staff side of the encounter. And does the on-call staff have the necessary hardware, connectivity? Where's the encounter going to take place from? Will it take place from the PACE center? Will it take place from, perhaps a Walmart parking lot? Where's this going to happen? Where there's connectivity and where's a reasonable place that the encounter can start? And I don't mean like out in the parking lot, but like, so if I'm talking about if the on-call nurse is in his or her car and they know that there's a spot in the Walmart parking lot with connectivity, it may take place there. And then start to consider bringing both parties together, the participant and the staff. So perhaps a mock encounter, and this could take place maybe initially in the PACE center, participant in one room, staff in another room, and just go through the mechanics of an encounter and how does that work and how does that flow. And really just, again, these are small steps to just start to, increase your chance of success when the rubber really hits the road and with a real on-call situation. And then further incentives that we consider are that back half of the data-driven core principle that we talk about is what metrics are you going to look at that are relevant to PACE and relevant to your telehealth trial that would shed some light on your program assessment. So again, staff or participant satisfaction, perhaps participant family or caregiver satisfaction, maybe miles driven by the nurse on the weekend, or number of visits completed by the nurse on the weekend, or emergency department utilization, any number of metrics. But again, like help kind of provide some incentive and provide a marker to, how's this going for us at this point? And then finally, inspire, the final tier, really. And this is more like this. I think the magic of this stuff is this is where you turn the corner to infrastructure. So you're talking about sustainable, ongoing telehealth practice capability. But what that really means to me is, have you considered or a protocol where, let's say, a future event, whether it's a pandemic or a widespread emergency, a giant earthquake or something like that, that limits the movement of people, participants, and staff. Do you have the ability, or or can you put together a plan where you could ramp up to total or near total use of telehealth, should you have to? It would involve some ramping up, but ideally, this routine use has kind of set the stage that you could pivot to this type of a situation without too much pain. And we also talk about expanding the telehealth encounters in this phase to other types of trials, maybe other consultants or specialists in the community, other facilities, kind of just broadening the use of telehealth. And then finally, share what you've learned. And ultimately, sharing what we've learned, I think starts to really achieve the goals of CDC and VDH with respect to, a simmering, improved preparedness for infectious disease crises in the future across the Commonwealth. And ultimately, what we envision is perhaps as we have further experiences with other congregate communities across the state with respect to telehealth optimization, we would envision maybe an echo-supported session like this, where everyone comes to the table with maybe a defined telehealth challenge or two, and we can gather and say, this worked for us, this didn't work for us, and kind of share ideas like that. Again, so that kind of we're part of that as well as a program from the standpoint of Virginia Impact. And so with that, I'm going to stop sharing here and go back to this. David, do you have anything to add to the
No, that was a beautiful discussion of what that has happened in that assessment. And I just want to say how incredible the organizations are out there that we've begun to have discussions with. We couldn't ask for better partners. We couldn't do this if those organizations weren't fully involved in their mission to support their patients. So it's remarkable to be a part of, and we're going to keep at it.
Yeah. Thank you both. Just to, add to what you were both saying, that it's really a privilege to work with the organizations that we've been working with so closely, to learn, their flow, their structure, what works well, where they think telehealth could be helpful, and how, our team certainly does not come to the table with answers. We don't, know exactly how this is going to be best, but, we try to come together as collaborators to think through the issues that are important to each facility and each group, and taking care of our patients and how we can best optimize that. And so it's been really exciting to learn more about different organizations, all the great things that are going on, and then see potential for where this tool could really help to really improve some of the processes that we have going on. So for those that are here, thank you for your participation thus far. We're really excited about those relationships, and happy to build more as we go forward as well. So with that, I suppose we will open up for any questions, discussion. Feel free to unmute, share your experiences with telehealth, or questions about what we've been doing, or put it into the chat. We'd love to hear from the community.
Looking at the chat, Pamela asked, has any information been collected regarding the possibility of increased confusion in patients with dementia? Citing a recent patient with dementia who didn't understand why her son couldn't come out of the screen, I guess, during a Zoom encounter to join her.
Yeah, so we haven't specifically been looking at that, but there are groups coming together and some of the folks that we're collaborating with to develop another kind of initiative is to look at patients or people with dementia and their caregiver and that dyad and how telehealth can be a tool. There are different ways to assess a patient's kind of telehealth readiness to kind of see where they are in that process. Those tools haven't necessarily been modified or looked at in patients with dementia, but I think that's something that could be very useful in terms of real world use with taking care of older adults, and then how to engage the caregiver there as well, whether that's the patient and caregiver on one side or the clinician and patient on one side, but to be able to build upon those tools that exist to really target them in our population, I think is work that would be super excited to see happening. Let's see, a couple of things are coming in through the chat. Okay, great. All right, so hearing Phaedra and Natalie are talking about their telehealth only experiences with challenges in connectivity, access to internet and smartphones, but that the patients are in general thrilled with the options and some barriers, but overall life-changing for their patient population. That's great to hear. Would either of you like to share more about your experiences and what you've been doing?
Yeah, I think my name is Natalie Jefferson. I'm a nurse practitioner with UVA Population Health. So Phaedra and I both are the two APPs. It's interesting that we both said this at the same time. However, yeah, we are a post-discharge readmission reduction program here at UVA. We have patients that have many SDOH needs, and we have a interdisciplinary approach and team. We have pharmacists, we have social workers and behavioral health specialists. We have what we call now case managers. They conduct weekly calls with the patients and connect them with our RNs or myself or Deidre whenever there's a clinical concern. And we conduct all of our visits through telemedicine. And it has been fantastic because we have patients that are rural, that are in the mountains, that are just, lack of access to care. And it's been just amazing. We do, to Phaedra's point, we've run into some challenges with patients that may not have internet or don't have a smart device. And so we try to work around that. But overall, the patients are very appreciative of the opportunity to receive care in their homes. And so that may not have transportation to a primary care appointment. So I'm just thrilled that this is something that is being utilized elsewhere and other places and across the system. And I think it's been great.
Fantastic. Thank you for sharing.
I think these efforts really represent a paradigm shift in the way we approach telehealth. And I think what you just described is a beautiful thing in the way that it needs to go. And that is designing telehealth from the ground up to meet the needs of the staff and patients of a particular organization, rather than having technology handed down to incorporate. We really are trying to base that telehealth in the way that Anthony expressed as just functional usage, how it fits in our day-to-day practice so that we develop a muscle memory in how to use it all the time. So it'll be there for us in emergencies and it'll be there every day for the patients.
Fantastic.
And we still have a long way to go. Can I just say we have a lot of cell towers that need to go up, a lot of simplification of technology, but this is the direction we need to move in.
Thank you.
Any other questions?
Hello. Yes, my name is David Driscoll. And I'm in the process now of attempting to develop some programs for implementation in Central Appalachia. David Cattell-Gordon is well aware of the programs that we have going on right now out here. I guess one of the questions that I had really dealt with the kinds of trainings that you provide for folks who are going to be using these technologies. You know, I anticipate that we're going to need some sort of a template, some sort of a training protocol. And I wondered if you all have something already developed that you might be able to share.
Yeah, we'd be happy to talk more about it in detail. Matrix, the Mid-Atlantic Telehealth Resource Center, has a lot of great resources on their site, from an education standpoint, from a process standpoint. One of the kind of tenets that we like to have is, we're not here to recreate wheels that other people have already done really well. We're here to kind of bring people together and share the work that can, really help everybody involved. And so that would be kind of my first thought, would be the Matrix website and kind of following some of those resources. There are also some on the CE4TA site, but happy to share specifics with you guys as well.
The other thing, David, that's been so helpful in our cases so far is really following that model of really understanding the mission and vision of that organization, going in there and having that on-site visit to really understand how it's going to be applied, and what that population and what those technology problems are, and just the ability of people to even use a device. How do we get through that hurdle and simplify it, and then take a small pilot population, as Anthony described, and really do a step-by-step. And I think we have a good model, and would really be happy to share it and share it in a model situation. Like we are very engaged too, as you know, in Southwest Virginia with this. And so I think there's a lot of potential overlap.
That would be great. So, David, as you know, we have these partners who actually are suggesting that they'd like to see more telehealth in their regions. And so I think our role might be as a liaison and support, organization, a source of expertise, if you will, in terms of how to implement these programs. Because I feel like we're being told that there's a need for it and there's interest in it, and folks are just not sure how to implement it.
Yeah, and technology shows up at their doorstep, and they go, how do we do this? And so by following those core principles, and we are happy to sit down with you, and how that becomes a sort of a foundation at Healthy Appalachia to expand out.
Perfect. Thank you.
Forward to it.
Excellent. I do want to plug next month we have part 2 of our long COVID duo, which is Talia Pollock. She's a physical therapist at UVA in the long COVID clinic, and she is going to present long COVID from a functional standpoint. So that will be next month on March 20th, same time, 12:30 to 1:30. I'll be sending out an email over the next few days, which will include or link to the recording of today's session, as well as our past sessions. It will also include this slide that instructs how to obtain CME credit, education credit for the session, and a newsletter as well. So you'll be hearing from me soon. So I really appreciate everyone's attendance, and it was great to share what we're up to as a team here at Virginia Impact. So really appreciate everyone's time.
Great. Thank you all for joining us. Hope to see you next month.
Thank you,
If
guys.
not soon.
Thank you.